Hey. Good afternoon, everyone. We're delighted to have you with us today. We are honored to host a very special Grand Rounds that's really focused on non-medical drivers of health. We do this in conjunction with our Mays Cancer Center and also with our American Cancer Society funded research center called Avanzando Salud. And today we have a very special speaker for you. But on the next slide, I'd just like to briefly remind you about the goals of our Salud Center. It's really to inform and introduce you to how excited we are to be partners with the American Cancer Society on helping promote health equity. Our center is dedicated to reducing cancer risks across South Texas and improving survivorship, quality of life, and to address access to care. We're aiming to address non-medical drivers of health, those everyday barriers that prevent our patients from seeking and receiving care, and also to learn better how we can integrate these particular factors into our research so that we can continue to make quality improvements in the care that we provide our patients. This is a 4-year grant. We're entering into year 3 of the grant. We have a special component, and we'd love to work with early career investigators. So if you're interested in the next slide in partnering with us, we would love to hear from you, from those, just for those that are engaged in or curious about cancer research that's focused on non-medical drivers of health. We invite you to reach out. Our website includes videos, flyers, and current scholar projects to help you learn more. We also you can also submit an inquiry form to briefly share your interest or ideas or to receive additional information from us. And if you know someone who may want to get involved in this area of work, please feel free to share our information with them as well. And now I'd like to just transition, and it's a great pleasure to introduce Dr. Miguel Mariano. Dr. Mariano is a first-generation Mexican-American scientist from Santa Ana, California, and he is professor of biostatistics in the Department of Family Medicine at Oregon Health and Science University. He received his undergraduate degree in mathematics from UCLA and his PhD in biostatistics from Harvard University. He is also the co-director of the Primary Care Effectiveness and Quality in Latinos Research Center, or PREMIER for short, where he focuses on development and implementation of statistical methodology to address the complexities associated with the use of electronic health records. Dr. Mariano is the statistical editor of JAMA, the Health Forum, and he was formerly the co-chair of the NIH Community Engagement Alliance Needs and Assessment Evaluation Work Group, and was also a member of the National Advisory Committee on Racial, Ethnic, and Other Populations for the Census Bureau. In 2022, Dr. Mariano was elected as a member of the National Academy of Medicine, and in 2026, he was selected as a fellow for the American Statistical Association. So it is with a great pleasure that I have to introduce Dr. Mariano to share his presentation with us. So Dr. Mariano.
Thank you. Thanks for the introduction. It really, I've had a chance to connect with Dr. Ramirez over the last few years. It's been just such a pleasure to learn from her and learn from a lot of her collaborators and just the way she sort of sees cancer research in Latinos. So I'll be sharing a little bit about what we've been doing with respect to measuring what we've been missing, with a specific focus on non-medical drivers of health and data disaggregation. So as Dr. Ramirez mentioned, I am a first-generation Mexican American, and I think so just a few notes about my background that will provide some insights into what informs my presentation and just generally my research overall. So I was born in Santa Ana, predominantly Mexican neighborhood in Southern California, and I still have family living in Mexico. So I will present a lot of ideas of work and focused on the Latino population, but several of the themes apply to a whole range of other populations as well. And second, as Dr. Ramirez mentioned, I'm co-director of the PREMIER Center along with Dr. John Heinzman, and this center is dedicated to understanding primary care effectiveness and quality for Latino populations. So the studies I'll present will be situated in primary care settings. But again, I believe the lessons will also apply to public health, to cancer research, and just the general academic setting. Um, the work that I'll present, I want to acknowledge comes from a host of different grants. So I just want to take a moment to thank our funders, several NIH institutes, the Silver Family Foundation, and our center partners, Department of Family Medicine, OHSU, OCHIN as well. What you're going to see today is sort of a breadth of work, but it, I'm not the one sort of doing all of that. The Premier Center is about team science, and all these people here have significantly contributed to the work we have done, and the work that we'll talk about today. So I feel extremely honored and grateful to be a part of this journey with them. And I do not have any financial conflicts of interest to declare. So we're all here because we understand that Latino cancer equity is an urgent and still unfinished problem. I know you are all very familiar with these numbers, but just wanted to put this on out there so we're on the same page, right? So let's just go through a super quick a few facts. So cancer is the second leading cause of death among Latinos, with nearly 200,000 new diagnoses and 50,000 deaths projected in 2024. We know certain types of cancers like cervical cancer incidence is 36% higher in Latinas than in white women. We also know that screening rates lag across most cancer types we measure among Latinos, and that about 28% of Latino adults are uninsured, so nearly four times the rate of white adults, and climbing up to 37% among foreign-born Latinos. So these are just not marginal differences. They do reflect structural barriers for which we have the tools to address, and we can measure them precisely enough to act on them. And that's what the rest of this talk is about. But the story is not entirely one of disadvantage. So before I dive into why these gaps exist and what we can do about them, I do want to take a moment to highlight and acknowledge where Latinos are actually doing better than non-Hispanic white adults, the majority group in the US. Because I think that story matters too, both scientifically and for the communities we serve. So, for example, lung cancer rates are roughly half of those in Latinos compared to white adults, likely driven by lower smoking prevalence. It's also been shown that melanoma incidence is 5 to 8 times lower among Latinos compared to non-Hispanic whites. And we also know that breast cancer incidence is significantly lower in Latinas, with mortality being a different story. But at least for incidence, it is lower in Latinas. And sort of several important papers have shown that Latino teenagers are actually ahead of their white peers on HPV vaccination. So these advantages are real, and many are tied to nativity and cultural protective factors that may erode with acculturation. But understanding what protects Latino health is just as important as understanding what harms it. And so here's the question I want to sit with for a moment. So we just looked at two seemingly contradictory pictures: a population in Latinos carrying disproportionate burden of some cancers and meaningful advantages in others. And so how do we make sense of that? My argument, and this is sort of the central thesis of everything I'm gonna show you today, is that this is maybe not a contradiction. It's potentially a coherent story with many interconnected dynamics at play. And I'll present two of them. You can think of many other types, but I think these two are important to highlight. The first is non-medical drivers of health. So, before called social determinants of health, use whatever terminology you want. But the patterns we just saw, both the burdens and the advantages, are not primarily driven by biology or clinical factors. They actually may be explained by who has insurance, what language do they speak, what neighborhoods do they live in, whether they are food insecure, whether they have trust in the healthcare system enough to walk through the doors. So these structural and social forces may shape cancer outcomes in Latinos more than almost anything that happens inside the clinic. Um, and then the second is data disaggregation. So right now, most healthcare systems and generally most research studies treat Latinos as a single group. But that single group contains enormous heterogeneity. And so today, I want to show you what we find when it is possible to measure some of the heterogeneity in the Latino population. So here's what I want to accomplish today. So first, I'll show you how we will use data disaggregation to move beyond Latino as a single category and why this matters for health equity research. And then second, I'll connect that to non-medical drivers of health that may explain most of what we see in Latino cancer disparities. And my hope is that this will sort of leave you with new ways of thinking about this problem and specific evidence that you can use in your own practice. And so we'll start with the topic of data disaggregation. And so why focus on data disaggregation? And so I think the pandemic was a really good example of why it was important to have some of these measures established. So in the beginning of the pandemic, there was an urgent need to know which communities were negatively impacted by COVID-19. And the best we could do when you're in a rush, sort of what's the best you could do? It's what's established. And the best we could do, given our federal and state data collection procedures, were figures like this one. So here's a CDC report that looked at the COVID-19 associated hospitalization rates by race and ethnicity in the beginning of the pandemic. And so in terms of understanding health disparities, what we typically see is that although the US is made up of a diverse racial and ethnic population, it typically categorizes into five distinct groups. So we'll have Latinos as the first one, then American Indian Alaska Natives, then non-Hispanic Black, then Asian American, Native Hawaiian Pacific Islander, and then finally white. And so, despite these broad categories, however, we know that significant variation exists in the histories and lived experience of those within each of these racial and ethnic groups, all of which can influence health outcomes. So for example, Latinos make up about 16%, 16 to 18% of the population. And among Latinos, three-quarters self-identify as either Mexican, Cuban, or Puerto Rican, which represents significantly different cultures and history. For American Indian and Alaskan Native populations, in the US, there are 573 federally recognized nations which differ ethnically, culturally, linguistically, and who have members who live on and off the reservation, which can influence their access to healthcare. Among the non-Hispanic Black population, that population in the US is around 42 million, of which more than 3 million are immigrants coming mostly from Africa and the Caribbean. And we know that migrant status plays an important role in healthcare utilization and outcomes. And when we look at the Asian or Pacific Islander population, they account for more than 17 million individuals in the US. And among all refugees that showed up between 2000 and 2010, half of them were Asian or Pacific Islanders. And so, again, similarly, thinking about non-drivers of health, coming to the US as a refugee has vastly different life experiences from those who voluntarily immigrated here. And then lastly, for non-Hispanic white people, they represent about two-thirds of the US population, but have the cultural diversity of three continents. And so this idea of data disaggregation, this sort of idea of breaking out data by more granular key characteristics could lead to the design and application of culturally appropriate approaches to medicine and public health. And this topic is not a new one. It goes back as far as 1985 with the Heckler Report. And then since then, multiple organizations, and including some US policies like the Affordable Care Act, have highlighted the importance of data disaggregation for improved understanding of health disparities. And it really could lead to new discoveries and culturally appropriate approaches to medicine that could improve health equity. And because there's still a lot we don't know about why some disparities persist, this could be an avenue potentially to understand why. Um, Take for example the following epidemiologic phenomena. So it's well established that broadly lower socioeconomic status, for example, things like low levels of income and education, is associated with mortality and morbidity overall. So it's just generally lower income, higher mortality, lower education, higher mortality and morbidity. And what the literature has cited over and over again is that relative to non-Latino whites, Latinos as an overall population have a lower socioeconomic status profile. So research has consistently documented that Latinos have some of the lowest household incomes, some of the lowest health insurance coverage, They have high food insecurity, among many other things. And survey-based studies consistently document that Latinos tend to have worse access to healthcare, experience worse morbidity as a result of lack of care or treatment, and they receive poorer quality of care when compared to non-Latino whites. And yet, even talking about all those things, Latinos they do generally have an overall lower socioeconomic status compared to non-Latino whites. But over the last few decades, research has consistently shown that life experiences is higher among Latinos than non-Latino whites. And this finding is known as the Latino mortality epidemiologic paradox. And there's a lot to unpack here that really could provide insights into what are the positive things that are contributing to health, right? So this is not, I mean, there's, you could think about morbidity as sort of one example, maybe as a counterexample to this, but really, like, it is showing that Latinos generally have a higher life expectancy. And so what are the things that Latinos are doing that are positive things that contribute to health? And this relative mortality advantage has been noted in major drivers of mortality. So, for example, when we look at cancer incidence and mortality, Latinos consistently over time have had lower overall cancer incidence and mortality compared to non-Latino white Americans. And so, just taking a step back, putting everything together, Latinos are a diverse and growing population. They are overall lower socioeconomic status, but that doesn't always translate to worse outcomes. There's a lot to learn about the struggles, but also about the resilience of the Latino population in the US. And this goes to a key takeaway from today's presentation. I think it's important to do these descriptive studies about race and ethnicity in health, but there is an opportunity to understand in a more nuanced and granular way who are the specific groups that are doing well despite their adversity, and how can we learn about those lessons and translate them to others to improve health overall across all groups. And so coming back to this figure, in reports like these and in the majority of medical research, Latinos are aggregated into this one group, and what we really want, and the goal is to get more granular subgroup information because specific place of birth and background and nativity may be important determinants of health. And so if you could start from scratch and say, well, okay, well, I have all this power. Let me see what are the things that I really, really want, the ideal setting for me to do this kind of work. And what kind of data would you be interested in collecting? And so ideally, we would like data sets to contain Latino subgroup information. So again, things like country of birth, background, foreign-born status, right? So those are the things that ideally, if I'm able to start from scratch, I would love to have that information. I would love to collect all relevant demographics, things like language preference, socioeconomic status, healthcare utilization, and maybe even some genetics data. All of that together with objectively measured healthcare outcomes in order to most completely study health disparities. And so what we know is that most common country of origin data come from surveys where participants get asked about about their background. And unfortunately, most surveys miss important healthcare utilization variables and are typically cross-sectional, limiting our ability to do longitudinal research over many years. On the other hand, electronic health records have been shown to be a promising data source for health equity research as they collect objectively measured health outcomes and important covariates. And importantly, they can be linked to community level non-medical determinants of health to be able to do multi-level longitudinal disparities work and really try to untangle some of these things we've just talked about. However, it is unclear if electronic health records routinely collect country of origin or nativity data, and there's always the questions of generalizability that limits our ability to do this important Latino subgroup health disparities research. Um, but having the ideal setting only really matters if the data being collected is actually of high quality. And so how well are EHRs capturing race, ethnicity, and demographic information that we need to do this well? And the Affordable Care Act under President Obama included a landmark provision called the High Tech Act, which created financial incentives for EHR adoption through something called the Meaningful Use Program. And this Meaningful Use Program had three stages basically. Stage one focused on capturing data. Uh, stage two focused on improving ways to exchange data across many systems. And then stage three was then to sort of use this data to improve outcomes. And this act worked. One of the few pieces of legislation that actually it did what it was intended to do. EHR adoption went from a minority of primary care practices to near universal coverage in under a decade. I think the latest estimates say over 95% of primary care clinics are now on an EHR. And this was generally transformative. I think within a decade, EHR adoption in primary care went from sort of a minority practice to universal coverage. And then we suddenly had longitudinal clinical data with real visits, real diagnoses, real prescriptions at a scale that had never existed before. Now, I know sometimes there's issues with EHR coding and all this other stuff, but at least we have a system that we could potentially think about connecting and leveraging to really understand health equity and health disparities. But one of the things we notice as working in this space is the quality of race and ethnicity data in research overall, but specifically in electronic health records. So in 2019, my co-center director, Dr. John Heinzman, and I published a piece in JAMA pointing out a critical gap that meaningful use left unaddressed, and that was race and ethnicity data. So despite all the progress in capturing clinical information, EHRs were still recording race and ethnicity in the crudest possible ways. Those five groups that we talked about. A single checkbox inconsistently filled in with no requirements to capture nativity, language preference, or country of origin. And so we sort of made the case that more access to data is not the same as better data. And for Latino health equity research, what we had was really not good enough. And so one could wonder, well, why do most EHRs have this broad categorization of race and ethnicity embedded in their system? And it's because we have federal standards for that. So the SPD 15 is the federal standard governing how race and ethnicity data is collected across government agencies. It was developed in 1977 and was revised in 1997. It doesn't require agencies to collect this data, but if they do, it does set minimal criteria. And it doesn't apply at the state level. So variation below the federal level is enormous. The 1997 version asked two separate questions. Are you Hispanic or Latino? Yes, no. And separately, what is your race? And those two question format really shaped EHRs. They shaped national surveys, local surveys, and research databases for nearly 3 decades. The good news is that SPD 15 was updated in 2024. That was the first revision in over 25 years. And the new version makes real progress. So race and ethnicity are now combined into a single question with Hispanic or Latino as not in a separate ethnicity screen. So it's there included with all the other groups. And critically for our work, the updated form includes specific subgroup checkboxes, including Mexican, Puerto Rican, Cuban, Salvadoran, Dominican, Guatemalan, plus open text fields for respondents to write in their own identity. So this is closer to what researchers like us have been asking for. The granularity we've had to build ourselves through statistical methods would now be built into the data collection itself. But here's the sobering reality. So the updated SPD 15 was published in March 2024, and federal agencies had until September 2025 to submit action plans describing how they'll come into compliance, and until March 2029 to actually get there. So the fully automated, the fully processed version won't be ready probably until 2029. So 5 years from publication to implementation across the federal government. And that timeline assumes political continuity, right? So we're now in an environment where the Census Bureau is being politicized, where a citizen question has been floated for the census, and where very institutional infrastructure that would implement these standards is under pressure. And so whether the updated SPD 15 gets fully implemented in healthcare, in EHRs, in national surveys, is really dependent on this sort of timeline being held up to. And that's genuinely uncertain. And so we may be asking for better data at exactly the moment when systems that produce that data are most at risk. And so, if the federal timeline is uncertain and the political environment is unstable, what can we actually do right now then? And the answer, I think, is to work locally. So states, health systems, and researchers don't have to wait for Washington to get this right. So, in fact, Dr. Heinzman and I made that exact argument in this 2024 piece in the Milbank Memorial Fund, really highlighting and suggesting that state health agencies have an underutilized but very powerful role in pushing health systems to collect better disaggregated data on Latino patients. The levers are already there. So health systems can invest in EHR infrastructure. They can invest in staff training to collect more granular data and to build the patient trust needed to do it well. So state agencies can set data standards and they can create reporting requirements that go beyond the SPD 15 mandates. And researchers can develop and validate the methods to make use of that data once that exists. So none of these actors can solve it alone, but they do have to wait. But they also, I mean, they also don't have to wait until 2029 either. Okay, so with that background and with the spirit of locally driven, research driven solutions, we asked, well, could we leverage our health system to understand the potential of data disaggregation in Latinos, right? So sometimes if you build it, they will come. And so our center primarily collaborates with OCHIN, which is a nonprofit health IT organization we have worked with for close to over a decade. And this company, nonprofit tech company, supports a national network of over 600 federally qualified health centers. So these are safety net primary care clinics that disproportionately serve the uninsured. They serve Medicaid and they serve a Latino patient. So about 1 in 6 Latino patients in the U.S. seek care at community health centers. And so through this partnership, we have access to over 2 decades of shared EHR data. We have real longitudinal clinical data at a scale and demographic depth really needed to make disaggregated Latino research feasible and to sort of show use cases to state agencies, to national levels about the potential importance of collecting this information. And so as you'll hear the rest of the findings today, so keep this in mind. So every study that sort of is coming from our center comes from a primary care clinic perspective. And these primary care clinics are clinics specifically that open their doors to everyone. So regardless of insurance, documentation status, or their ability to pay. So this is not incidental to the findings. It is the reason we can study the populations we are most interested in, is because of this particular setting. Okay, so given our interest in data disaggregation of Latino subgroups, well, we asked, well, does the EHR in this network of community health centers, does it even have place of birth data that would allow us to start thinking about this data disaggregation work? And so one of the first things we did is we endeavored to describe the extent to which country of birth is recorded in EHRs and Latinos across the OCHA network. The first surprising thing is that that there is a discrete EHR field, and this is an Epic system, and they actually had a discrete field that you could input country of birth. So that was one of the first shocking things is actually it is available for all these clinics to capture it. And what we found was that hundreds of clinics across 22 states out of the 26 total study states recorded at least one patient's country of birth. And just to give you a sense of the scale and the challenge, so in this study, we had about 915,000 Latino patients across 26 states, but only 14% or about 127,000 Latino patients had a place of birth documented in their EHR. And this was a sobering data quality finding. But here's another way to also think about it is even at 14% documentation, we still had 127,000 Latinos with nativity data, more than most studies focused on nativity in the scientific literature. So imagine what becomes possible if we could get that number to 50% to 80%, you know? So that was one of the first key findings is there is some data here. And so how can we leverage that to understand Latino health outcome, and in particular for cancer, and I'll be showing some cancer studies soon. So just as a use case to really try to drive the point home, in the same study, using cardiovascular disease as a clinical test case, we aim to highlight what happens when you start utilizing this nativity data. So here we took the 14% that had nativity data, and we displayed prevalences of cardiovascular disease and risk factor diagnoses among the three major ethnicity groups. So we used the nativity data and created three groups. We created US born Latinos, we created foreign born Latinos, or what's labeled here, non-US born Latinos, and also Latinos with no place of birth recorded. So the Latinos that did not have a place of birth recorded, we still included them just so that you can have a comparison group there as well. And we see what we see from this plot is that foreign-born Latinos had a lower adjusted prevalence of obesity, so they were less likely to be obese than the other Latino groups. But for the most part, the diagnosis prevalences of all these conditions were similar. However, when we then disaggregated the data into specific country of birth, there is increased variability in findings between countries, especially Latino countries, especially in hyperlipidemia, hypertension, and diabetes. So, for example, the prevalence of hyperlipidemia denoted here in the middle panel it is a significant risk factor for cardiovascular disease, and it ranges from about 15% for Cubans to about 28% for Mexicans. And a similar pattern is observed for in obesity prevalence. So this country of birth disaggregation allows us to think about in what clinical settings this kind of data collection may be important to collect. And the big limitation of that prior study is that close to the 1 million Latino patients in the network, country of birth was collected at only about 14% of those patients. So there's still a lot of Latino patients that are left out of further analyses. And so one of the goals of our center was to improve approaches to studying Latino disparities by developing and validating new statistical methods to do Latino subgroup data disaggregation for the purposes of producing these more nuanced health equity research among all Latinos. And so what we aim to do, as illustrated here in the top right, is to break up this large Latino category into more granular subgroups to fully appreciate the heterogeneity of Latino populations by trying to utilize all available Latino data and not just ignore or throw away the thousands of rows of valuable information that Latinos provide here in this network across the US. And so we started off by thinking about what could a machine learning approach in this setting be useful as a way to sort of infer nativity for the 900,000 Latinos who had that missing information. And so in this study, it was a small pilot study of asthma among Latino children. So this was just children an asthma study. And so we used the superlearner machine learning framework, and we particularly fed it three things. So we fed it some surname data. So using Latino surnames as a way to categorize them into different countries of origin. We also fed it clinical data, and then we also fed it neighborhood level data. So we use census data to sort of say, well, you know, where do you live? And in particular, what does that neighborhood look like in terms of percent Mexican, percent Cuban, percent Guatemalan? And that sort of is information that we can leverage to infer nativity here. And this table here shows that we were actually able to infer with good accuracy foreign-born status and specific country of birth, but only for three countries, Mexico, Guatemala, and Cuba, due to sample size restrictions. So all models showed outstanding discrimination between foreign-born status and specific country of birth. And so at this moment, before we move on, I do want to highlight that our proposed methodology here is not intended at the patient level to help provide care, nor it would be ethical to assign nativity designation to an individual apart from their own self-identification. So at the present, this approach is not suitable for clinical or healthcare use, nor for policy decisions. We recognize that prediction algorithms are imperfect and they cannot replace self-reported nativity and country of origin. But we hope that this provides a starting point about when and where this data should be collected, especially when you think of the context of very busy primary care clinics. You kind of have to show them the value of this kind of stuff if you want primary care clinics to invest in collecting this information. So we think we can start with this, show some really interesting findings, maybe show that it is important to collect as a way to sort of motivate primary care clinics to invest in infrastructure to collect this information. And so while that study was just focused on a pilot study of about 40,000 Latino children, we wanted to see if we were able to extend these predictions to adults. And so in a more recent data pool, we utilized about 1.5 million adult Latino patients in this community health center network. And we saw that among adults, country of birth was recorded in about 12% of Latino adult patients. And then similar to what we did in the prior study, we developed a machine learning algorithm to infer foreign-born status and specific country of birth. This time, just using two pieces of information, just your surname and your neighborhood level composition. And even with that, we saw outstanding prediction of those two things, the foreign-born status and specific country of birth among Latinos. And again, our goal is to use those uh, predictions in subsequent disparity models, like the ones shown on the top right, so that we can start working on its utility on that end. And so, as a test case, this what we did is we used these model predicted probabilities of Latino subgroups to evaluate colorectal cancer screening disparities by Latino foreign-born status. So in this example, we just subset it to Latinos, subset it to those eligible for colorectal cancer screening, and we said, is there a difference between U.S.-born and foreign-born Latinos? And so in this case example, using foreign-born status of Latino patients, using the actual EHR known status here in blue, that's the model one, we observed that U.S.-born Latinos had lower odds of colorectal cancer screening compared to foreign-born Latinos. So when you actually use the information that's provided in the EHR, it seems that U.S.-born Latinos have lower odds of colorectal cancer screening compared to foreign-born Latinos. So when we replace that known status with predicted probabilities and rerun the models, those are models 2 and 3, we do see that there's an association in a similar direction, but it is slightly biased. And then when we expand it to these predictions to the full sample, we see that it's also biased in a way. So this is just a simple use case, and we're actively working on methodology to address this bias, but it does show some promise. And so what do these disaggregation methods actually reveal in practice? And so now we'll go through a few studies where we've done some work in trying to understand this data, and so now we're going to apply this data for several cancer-specific outcomes. And so we'll start with breast cancer. So in our center's study, this one's published in the Journal of Racial and Ethnic Health Disparities this year. Among nearly 25,000 patients across 18 states, we found that both US-born and foreign-born Latinos were significantly more up to date on mammography than non-Latino white women at the same clinics. So foreign-born Latinas had nearly twice the odds of being up to date, and across all Latino subgroups, time to first mammography after the age of 50 was faster. So they actually had it faster than non-Latina white women. So here, as sort of shown in other studies, it seems that the CHC setting appears to be buffering some structural barriers through culturally competent care and really proactive outreach. We know that they do that for Latinas. Uh, but the regional disaggregation reveals important variation too. So here on the right, you see that South American origin Latinas had the fastest time to mammography when eligible from any group. US-born Latinos, while still ahead of non-Hispanic white women, were the slowest among all Latina subgroups. So without nativity and region of origin disaggregation, that variation is completely invisible, and so are the groups subgroups that may still need more targeted support, like potentially U.S. born Latinos and others. Mammography showed where disaggregation reveals an unexpected advantage, and so lung cancer screening here shows where it reveals a gap that may otherwise be missed entirely. And so in this study, we published among 126,000 Latina and non-Hispanic white patients. We thought the overall prevalence of lung cancer screening was just about 7.3%. It's remarkably low for a guideline recommended test, but nativity tells a different story. Among patients with documented 30-pack year history, US born Latinos had equal odds of being screened as non Hispanic white patients, and foreign born Latinos had roughly half the odds. So the same eligibility, different outcomes. And this ties directly back to our disaggregation theme. So pack year history and nativity were not collected in most patients. We can't screen who we can identify as eligible. Measuring what we're missing is itself a clinical inequity intervention. Um, I'm gonna just given time constraints, I'm gonna move on forward to a few slides. Um, I do want to spend some time talking about the second topic of my talk, which is the non-medical drivers of health and what they mean for cancer equity in Latinos. So just so we're on the same page, we understand that non-medical social determinants of health are the conditions and environments where people are born, live, learn, work, play, worship, and age that shape health outcomes and risks. And we know that these economic and social environment forces matter tremendously. And so one of the first ways we explored where we live was through the study of nearly 24,000 children with asthma across 15 states. And so one of the strengths of the OCHA and EHR system is that when patients come in to seek care, they provide their current address, and we're able to connect those addresses to neighborhoods through geocoded address data in longitudinal manner to be able to characterize their neighborhood experience across potentially several years, and we're able to see how often they move and what neighborhoods they move to. So in this study, looking at the figures on the left, we see that over half of addresses in our network were not initial addresses. And so here we have to grapple with the fact that neighborhoods themselves change over time and that people are a highly mobile society. And so when we accounted for mobility, we saw that more moves meant less care, as shown on this table on the right. But moving to high deprivation areas was associated with more utilization. Patients in deprived neighborhoods engaged intensively when they do access care. And so this brings me to the theme of the talk. So measuring what we're missing. So most studies take a single snapshot of neighborhood or social risk, but what we really need to capture is the total lived experience. So cumulative deprivation, repeated moves, years of instability. I think that's what's also may impact cancer screening behavior. And that could be a potential reason for late stage cancer diagnosis. And that is what's been hard to capture even in national surveys. But perhaps leveraging the EHR system and its routine capture of patient address data that is linked to community level data could be a good starting place. Continuing on where we live, this Premier Center study looked at HPV vaccination among 212,000 Latina patients and Latino patients across a national CHC network. And so the finding was that higher neighborhood deprivation did not consistently predict lower vaccination. So the CHC setting again seems to buffer against neighborhood disadvantages by design. But disaggregation still revealed something important that patients with a documented country of birth, so those where the clinic actually collected that, had meaningfully higher vaccination rates than those without documentation of their country of birth. So we think that this is not only a clinical finding, but it's potentially a data quality finding. So thinking about the act of collecting more granular nativity data may itself be associated with better care with respect to HPV vaccination. And so when we think about where we work, occupation is a perfect example of non-medical drivers we can actually capture in clinical data. And in Ocean, migrant and seasonal farm worker status is routinely collected and documented because it's been mandated by the UDS system for federally qualified health centers. Network are populated with information about whether a patient is a migrant, seasonal farm worker or not. And so this gives us something rare, a large longitudinal data set on a population that almost never appears in health research. So in this study published last year in Ethnicity and Disease, among over 21,000 Latina women aged 50 to 65. We saw that migrant seasonal farm workers had higher cervical cancer screening rates than non-farm worker Latinas, so about 59% versus 49%. And that ran counter to our expectations. I think the likely explanation is that CHC settings which include promotoras and culturally tailored care, and providers who prioritize preventive services for mobile transient populations. So that may have just kicked in, and they might have just done a better job there. But it's an interesting point that we're still trying to understand and figure out. And then the farm worker study just reminded us that occupation is one of the many non-medical drivers of health, shaping healthcare and utilization and outcomes, but it's only useful if health systems actually capture it. And so social risks, things like food insecurity, housing instability, and transportation barriers and financial strain are among one of the most powerful predictors of whether a patient can access and follow through on care. And so that brings me to this broader question: are we measuring that and documenting that these drivers of health in the EHR equitably in the first place? And this was a priority for Ocean clinics, and Ocean built discrete EHR fields for which health systems can document social risk information across the entire network of patients. And so in this study, we sought to identify how often social risk screening occur and to see if there are differences by patient characteristics in those screenings. And so here we had 650,000 patients across those states, and social risk screening occurred in only 30% of health centers. So you turn on the tool, see what happens. Only 30% of health centers used it on just 11% of eligible patients. So screening only happened 11% of the time. And then when we disaggregated by race, ethnicity, and language, we found that Spanish speaking Latino patients, especially those with the highest burden of social risk, were among those who were least likely to be screened for those social risks. So seems to be a big barrier in who is getting screened, and in particular, Spanish-speaking Latino patients were the least likely to be screened. So now we move from who gets screened for social needs to what happens when those needs are actually documented. And so this paper led by Dr. Banegas from UC San Diego, he asked directly, well, what social risks are associated with cancer screening in CHC patients? And so two findings stand out. So first, social risks don't just affect whether a patient completes a cancer screening, they affect whether a provider even orders it. So for example, here, food insecure patients were less likely to have any of the three cancer screening ordered at all. It really highlights the disparity may start before a patient even has a chance to act. Second, the relationships are specific and they're not uniform. So food insecurity and transportation barriers are associated with lower completion of cervical and colorectal cancer screening. But breast cancer completion showed no difference by social risk. So you only see that nuance when you look at specific cancer types and social risk together. And this is exactly a disaggregation argument in action. Moving to another non-medical driver of health, insurance is arguably the most single powerful structural lever we have to improve cancer screening equity in Latinos, and we have natural experiments to prove it. So in 2021, California and Oregon made a landmark policy decision. They decided to expand Medicaid eligibility to all income individuals, regardless of immigration status. This was the first time a state had really expanded public health insurance coverage to undocumented immigrants at this scale, and it made national news. So for Latino health researchers, it really was, allowed us to look at this natural experiment, see what the impact of this was on cancer equity. So here's where EHRs become essential. So insurance status is captured at virtually at every clinical encounter, and it's one of the most consistently documented variables in the EHR. And that means we can track coverage over time, we can link them to clinical outcomes, and we could study what happens when people gain or lose insurance in real time. So context matters here. Community health centers, as a reminder, are federally funded, and that requires them to report insurance status for every patient at every encounter, and that includes the uninsured. And that is rare. So most data sets simply just do not have enough uninsured patients to study this rigorously. And so community health centers are one of the few settings in the country where we can actually do rigorous research on what happens to uninsured patients and what changes when coverage expands. And so utilizing this unique feature of EHRs in our network, we produced two papers this year that examined what happens to cancer screening rates in Latino CHC patients as a result. So the first on the left found that among previously uninsured Spanish preferring Latinas, breast cancer screening increased by over 9 percentage points and cervical cancer screening by over 11 points compared to Latinas in states that had Medicaid expansion through the ACA, but they did not have the specific coverage expansion to individuals regardless of documentation status. So this new Medicaid expansion focused on documentation status is really increasing or is showing an increase in both breast cancer and cervical cancer screening. And the study on the right found that colorectal cancer screening increased significantly among Spanish preferring Latina women compared to Latinas that did not expand to individuals in states that did not expand to individuals regardless of documentation status. So we also observed that this policy significantly improved colorectal cancer screening among English preferring Latino patients. And this was important because this group started off with some of the lowest baseline rates of any group we've studied. So both papers really show the effect of this expansion. I'll conclude. I'll sort of give a sort of quick recap, and then we'll hopefully have time for some discussion. But I do want to sort of give a few reflections. I think what's important to think about is, what do we do with all this information, right? So I think first, let's continue to think about how do we measure better. So, if your EHR is not routinely capturing nativity, language preference, country birth, well, maybe it's trying to figure out how to prioritize that. And we also maybe time to ensure how does social risk screening reaches your highest, risk patients, and how do we do that effectively and culturally appropriate and safe is still an important question to do that. And then second is we should target differently, right? So we should reconsider programs that treat we should reconsider the programs that treat Latino patients as a monolithic group. So we've seen that foreign-born status, Spanish-speaking, those people we just know that those patients may have lots of differences with the U.S.-born English-speaking fourth generation types of patients in terms of barriers to cancer screening. So how do we sort of target that differently? Third is sort of putting on your advocacy hat, thinking about what are the levers we can do. So like one of them is the insurance, right? So the insurance was a great example of several levers that we can use to expand insurance. And then fourth, community building, as always, sort of promotoras, community health workers, patient navigators, who are often found in community health centers are not a nice to have. They are infrastructure. And so building trust with communities takes years and it really can't be retrofitted into a screening program. And so what we want is sort of a way to sort of have that continually happening, community building, working together to not only improve health outcomes, but also think about ways to increase the research workforce for the next generation of Latino health researchers. So thank you. I'm grateful for the time and attention, and I'm happy to answer any questions.
Well, Dr. Marino's a fabulous presentation. Thank you so much. So much data has gone into it, and you're looking at it from different angles. So we're very grateful for you taking the time to sharing these new approaches with us and how to reconsider some of the data that we have. I was interested in your comment on the use of the electronic medical records. We know that patients are being asked to fill out these forms that collect some of the non-medical drivers of health, right? But they're not always utilized in clinics. Any thoughts on how to better get them to come up with better summaries so that, systems can be more responsive?
That's a great question. So I've done a few studies with some collaborators from Ocean and from UCSF. One of the big issues is the clinics themselves are hesitant to collect because they don't know what to do with this information, right? So if the clinical leaders say, hey, you must collect whether someone has housing instability, if the clinic collects it, they click yeah, the patient clicked yes. They feel powerless to sort of change anything. And so a lot of it has been sort of buy-in, like, well, help us think about how do we act on this information if we collect it. And so there's been some like pilot programs trying to connect to actual like community resources. And so that is one approach. There was another natural experiment we studied where I think it was Oregon, yeah, Oregon and California offered financial incentives to collect this, and it was like $10 a screening or something like that, and that did not have any impact on increased screening. So it basically seems like we have to figure out a way to give guidance on to the clinics themselves. What do you do once someone is identified as food insecure, right? Do you connect them to an organization that deals with that, or do you have your own program that might help with that? So I think that's something to consider.
Thank you. Well, I'd like to open it up to any to our audience. If you have any questions, if you just either unmute or place your question in the chat, and Dr. Marino will help us answer. There was a comment there, Dr. Marino. I don't know if you see it, from Diana Monaco. She's the
Yes,
reversal.
yes. So the reverse also occurs and impacts data collection. Most folks don't want to identify the race due to lack of trust and fear regarding immigration laws. Yes, and I think that's the important part is this is not a morally neutral exercise, right? There are trust issues, there are imbalance issues, and the U.S. government has had history of nefarious acts using information like this. So I think it is a tricky situation. It is one of the reasons why when I gave this talk at the National Academy of Medicine, some similar talk, some about our methodology, and one of the clinicians there said, oh, this is really good because then there's maybe ways to say, well, if it's unsafe, maybe use the predicted probability instead of asking the person as a way to sort of get around that. So it's this balance we still haven't figured out, like when should we ask and when should we use sort of these novel methods to infer as a way to keep safe. But at the same time, I don't feel comfortable inferring people, right? So as a statistician, I'm the one doing this, and in a perfect world, I would love to have just someone self-identify, but at the same time, there's these issues of trust, and it's something we wrestle with. It's something that it's probably a reason why the collection rates, at least in settings like community health centers where people see them as safe, it's still pretty low at about 12 to 14%. So it's a great question. It's something that we're trying to balance. We're trying to figure out ways to address that, and it is there's no straightforward answer, especially in climates like the last decade. So
Correct, correct.
look
Now
for
we're
that point.
seeing fewer people wanting to self-identify, as they're coming in for healthcare. So we're kind of seeing a little bit of an increase in that area. So,
Absolutely.
a- any other questions for Dr. Marino? Yes, Diana.
Yeah, so just really quick, what would be the perfect solution? And what I mean by that is, have we thought of other creative ways of collecting the data, maybe in a de-identified format where they enter a survey, but they never enter their information? And it's the folks that are actually coming into the clinic where you're able to really um, go down into granularity and have somebody who can sit with them and help them fill out the survey without actually collecting their name. And then you would get maybe a wide base population database of who is coming into the clinic, and then based on the types of treatments, kind of cross match it with the types of treatments that are occurring within the clinic or diagnoses within the clinic. Then you could do a more generalized assessment of, the narrowing down of these specific populations. Just some thoughts, but can that happen? Is that you know, a a good way, an affordable way of collecting the information that we need without putting these folks at risk who are already feeling lack of trust in the system. Over.
Yeah, and that's very similar way of thinking that we've been doing with these predicted probabilities, because what we're doing with these predicted probabilities from these machine learning algorithms is we're essentially doing similar things where we're not asking them, we're using what the data we've already had of people who have been asked, to infer that, roll that up to a group, and then put those groups in the right hand side of the equation as a way to understand, so it's very, and what you're proposing, I think, sounds very similar, but at a clinic level, which is even more granular and probably more robust. So yeah, I agree that we do need clever ways to improve this data collection in a way that's very trustworthy. I do think that there's probably other way. The other approach could be to, in a similar way, um, increase trust between patients and the health system, and provide rationale. Why is this for the patient? Why is this information? Why are we collecting this information? And for the clinician, why is this information important to collect? And I think that's why it's like a chicken and eggs. Like you can't really say it's important to collect without rigorous research showing that it's important to collect. But you can't create rigorous research important to collect if there's no data that you can use to show that reason. So it's this chicken and egg, and the idea is we just chip away at sort of showcasing when it's important, why it's important, and then sort of think about cleverly how to if you were to collect it, how would you do it safely, or or like approaches to this collection over time. It's really a hard conundrum we're in.
I just want to follow up with what you're saying. I think that's where there's a lack of, or there's a lack of community education, right? Because even within the clinic, patients will sit there and wait for their physicians or their clinicians for a long period of time. And there's an opportunity to have these short videos that kind of explain what you're looking for, why you're collecting certain data. Because I can tell you right now, my elderly mother, when she's gone to the clinic and they start asking her questions that are unrelated to her health, she gets very anxious. And I luckily I'm sitting there and I'm like, well, mom, they really need to know this because, but they don't have, a lot of these patients come in and they don't have that. And they don't have anybody explaining it to them either. They just know that they're being asked very, what they consider intrusive questions, when it already took like 10 steps to try to get them to the doctor because they don't trust going to the doctor because you go to the doctor so that they can diagnose you with something terrible. And so, explaining why we're collecting these non-clinical questions and the purpose of them and providing that community education in very simple terms, you know, first grade, second grade level, I think would really go a long way because they do pay attention. They just don't understand. And I know that our standard is third grade or fourth grade or sometimes even sixth grade. But when we're talking about Latinos, especially migrants or immigrants that come from other countries, their level of education is even lower than that. And so we're missing a huge opportunity to just get them up to par with understanding why it is we're collecting what we're collecting over.
Yeah, I agree. And what you just described sounds like a really great pilot intervention um, that would be helpful to help us sort of think through those issues. I also would say that like these community health centers have promotoras and community health workers who are really culturally adept at some of the things you've discussed. And so I think that's an important thing that non-CHCs I think could learn from CHCs to extend this to the Kaisers, to the the private clinics, the primary care clinics, is having these additional resources to help in those culturally appropriate approaches.
Well, thank you for the question, Diana. And again, Miguel, thank you so much. It's really been an honor to work with you and your group and for really forging ahead and helping us really look at how important it is to disaggregate data and learn more about our Latino community that it continues to grow and needs our help in navigating the non-medical drivers of health. So again, thank you so much. And look forward to having you back again. All right. Thank you. And
Thanks.
thanks everybody for joining. We'll be back in another few months. If anybody has any suggestions of a speaker you think we should invite, please let us know. All right. So thank you and go visit our website as well. Thank you. Have a
Thank
great
you all.
afternoon. Bye-bye.
Bye bye.
Thank you again, Miguel.